Hi, this is Mrs. White, and welcome to the HIV lecture. Today we are going to talk about HIV, the recognition, the stages of HIV up to and including AIDS, and care of the patient. Little statistics to start us with are that you can certainly read this, but what we get out of this is that there are a lot of people in the United States are diagnosed. These are some of the more up-to-date statistics from 2020. Male-to-male sexual contact does still account for the largest amount of new cases, but see that heterosexual contact does account for 22% of all of HIV diagnoses. 14% of people infected in the US are actually not aware of their diagnosis. When we start to think about HIV, we have to take a step back and look back at the immune process in our body. Now, we have something called natural immunity or innate immunity. Basically, that's what you're born with. It's standard equipment on the model that you have, assuming that you were born without an immune disorder. And in this, what happens with natural immunity, macrophages recognize and ingest foreign cells and things like virus, fungi, and then they take that ingested material to the T cell, and then the T cell then produces memory cells that stimulate antibody production. And then we have those dendritic cells. They act as messengers between the innate and adaptive immune system. And I want you to go back and look at B cells and T cells. Right, so B cells are from the bone, and they produce antibodies. And that's a little slower because antibodies have to be produced, and they are very highly specific. And T cells mature in the thymus, and those are the guys that can do hand-to-hand combat. And of the T cells, we have a breakdown of different cells. We have the effector cells, and of those are the helper or the CD4 cells. Those are the ones that are targeted by HIV. Then we have the cytotoxic CD8 cells, which are, they recognize cancer cells, not necessarily affected by HIV, but their numbers become affected by the HIV process. Then we have the regulatory T cells, and those keep the numbers in check to provide immune response, to make sure that we don't have too much of an immune response and also not too little of an immune response. And then we have acquired immunity, so that could be either passive or active. So passive is that short-term immunoglobulin infusions, monoclonal antibodies, maternal transmission, infusion of ready-made antibodies from an immune person. And then active immunity, that's by contracting and surviving a disease or vaccines. And I want you guys to just look back and look at that herd immunity concept, right? That's the concept that if a significant percentage of a population has been vaccinated, and those that cannot be vaccinated are protected. So HIV is a retrovirus that causes immunosuppression. So retro means that it makes RNA into DNA, which is backwards. And since it's a virus, it can only reproduce using the cellular machinery of other organisms. Most viruses are not retroviruses. And HIV has 2 identical strands of RNA and 3 enzymes. And we will look to that a little bit more later in the patho. It used to be very deadly, but now is known and considered as a chronic disease. So as we go through this lecture, we're going to kind of do a little case study along the way. So we'll start with part 1. Okay, so you have AO, who's a 20-year-old Hispanic male college student who's come to the health center reporting pain on urination. His urine test is positive for Neisseria gonorrhea. What should you do? You can pause and think here for a moment. We can also more than likely get to discussing this in class, but what would you do if this patient were in front of you? and he's positive for an STD. So we're going to go back to HIV now. So HIV is spread through contact with infected blood, semen, vaginal secretions, and breast milk. An important concept is the higher the viral load, the higher the risk of transmission. Sexual transmission is the most common, and the receptive partner is more at risk. It can be spread through the blood supply. Even though we screen the donors, there still remains a chance, which is why anybody who gets a blood transfusion has to sign an informed consent for that. Occupational hazards with risk increasing with large bore hollow needles. And then perinatal spread, 25% without treatment. And with that, severely affected infants may survive less than 18 months. So there's a 1 in 4 chance of spread from the mother to the baby. With treatment during pregnancy, however, that number drops to 2%. All right. So sexual transmission, we already touched on, but to remember that the greatest risk is for the receptive partner, the one that receives the semen. And that's puts women at higher risk, and male to male, the receptive male partner, because of the potential trauma, and that increases the likelihood of transmission. Contact with blood, especially occupational exposures for nurses, is something to be considered, and other healthcare workers. Think about those high-risk environments, dialysis, the operating room, believe it or not, because they're using large needles, boring materials. And then also there is the potential for just drug paraphernalia. So those who are engaged in drug use with sharing needles is a very big risk. And we've kind of talked about this as well just in the previous slide, which is the perinatal transmission. And again, 25% of infants with untreated HIV will get the infection, which, truly speaking, isn't that huge of a number when you consider the risk involved. But that 2%, that's what we're after, right? We can really reduce that and make a change for the infant. So remember, HIV is a retrovirus, right? That's backwards. It is not the normal process. Normally, cells go from DNA to RNA, not RNA to DNA. And we already spoke to it, and here it is a reminder that CD4 T cell is the target for HIV. It's a lymphocyte. The HIV binds to that cell because the HIV has protrusions that dock to those receptor sites on the CD4 cells. So some of the patho, again, it has to be in a host to reproduce for the HIV. And after infection, there's a latency period before a person actually shows signs of symptoms. And here's the actual process by which we are going to have binding to the cell. All right, this is figure 14.2 from your textbook. So the process is that first is fusion. HIV binds to the protein receptor on the outside of the cell, which are glycoproteins 120 and 41. It's a two-step docking process. Needs to be in 2 receptors, though, guys, there's new variations that require only 1 receptor. Once there, it uncoats and shoots the enzymes and the RNA into the cell. The HIV RNA enters the cell and releases reverse transcriptase, in which the RNA copies itself, becoming a double DNA strand. Integrase then allows the newly formed DNA to insert itself into the host genetic structure. that forces the cell to make copies of itself, infected copies of itself. And HIV, at this point, this is infection and it's permanent. Protease enzyme then slices the new HIV into smaller pieces called virions, which are then released into the bloodstream where they infect other T cells, and the CD4 cell is destroyed. A little reminder here that the CD4 cell is truly the cornerstone of immunity. Changes in levels of the CD4 cell affect the immune system. And the numbers that we look at are greater than 500, the body's not at risk of increased infection. Less than 500, immune problems begin to occur. And if that CD4 count drops to under 200, severe problems occur. So integrase is very important to HIV, right? Integrase is what allows the DNA to insert itself into the cell's genetic structure. So I wanted to just draw your attention to integrase. And the three different enzymes that HIV releases, reverse transcriptase, integrase, and protease, those are the basis of the medications that we'll use to fight HIV. A couple little more things about the CD4 count in HIV itself. The HIV half-life is 6 hours, and you can kind of follow along by this. 100 billion HIV viruses are generated daily, which infects 2 billion CD4 T cells. And over time, as we have more HIV, we have a net loss in our CD4 cell. Once that CD4 cell count drops, and those numbers I gave you already, once it drops below 500, we have immune problems, and less than 200 is severe problems. Normal range for our CD4 count is 800 to 1200. But again, we have the ability to fight infection as long as we remain at 500. So that's just another little zap at you to look at it. And then viral load. This is a map that shows basically viral load in response to the CD4 T cell counts. So basically in our acute infection, you have a high viral load. The body then gets a hold of it and drops the viral load, and the CD4 count remains, after the initial dip, remains a little bit higher until those HIV levels increase, eventually decreasing our CD4 cells. All right, let's go back to our student here. It says he informs you that he's been sexually active since he was 15 with both males and females, and he states that he's always the on top or the inserting partner. So based on what we know already, what do you think about his risk factors for HIV? It says that he's had intercourse with 3 people in the last month, because we ask him about that, and he doesn't use protection. So what should you do next? You can pause here and think, but if you haven't already recommended it, further testing for other STIs, including HIV, is in order. Inform him that testing is the only way to determine if he's contracted HIV. Negative results can relieve anxieties about past behaviors and provide opportunities for preventative teaching. And positive results can provide an impetus for him to seek treatment and provide and protect his sex partners. You need to talk to him about ways to protect himself and others from sexually transmitted diseases. And among those are abstinence, non-contact sex, and the use of barriers. All right, so back to our HIV. Here's the timeline for untreated HIV infection. Again, once we have infection, after the initial acute infection, we have an asymptomatic infection for some time, which can be up to 8 to 10 years. where the patient is generally healthy before they become symptomatic within the infections and then eventually into AIDS. It's another picture for you to look at the different stages of AIDS and HIV and AIDS. So we will talk about them as we go through. So we have the acute infection, latency or chronic HIV, and then eventually AIDS. All right, so what happens in acute infection? Acute infection is when there's seroconversion. Antibodies can be detected in lab work, which occurs 2 to 4 weeks after the initial infection. Most folks who experience this complain of, sometimes they say it's the worst flu that they've had in their life, but pretty vague and nonspecific overall, mono-like symptoms, and I have them listed for you. At this point, the person's body is making a lot of HIV copies, and the person gets sick as their body starts to fight. And the person at this point is very infectious. The person at this point has a very high viral load. So initially there's a drop in CD4 as the body recognizes and fights the infection. CD8 starts to actually target the infected CD4 cells. And remember, they're very infectious. The higher the viral load, the more transmittable it is. And then there's this window period. So the window period is a time when there's a high viral load, but it's not yet seroconverted. They will test negative due to the lack of antibodies. 40 to 80% do complain of the fever, fatigue, the rash that lasts 1 to 2 weeks, and then the seroconversion will occur generally 2 to 3 weeks, and that's when the antibodies develop to HIV. At this point, the person is developed the antibodies, but they don't have the ability to control the virus. Once that occurs, though, the viral load is actually rather suppressed by the body's immune system, and if we do have that, what we want to find out at that point is the viral set point. That's the amount of virus in the body after the initial immune response subsides. So after those flu-like symptoms subside, what is the viral set point? The point behind that is that the higher the virus set point, the worse the patient tends to do overall. And that's because the body didn't fight the virus enough. They end up with a higher set point. So this can kind of help you. HIV stage 1, the acute infection. So when you have you end up with HIV confirmation and your CD4 count is at least 500 and you have no AIDS defining conditions, those category C conditions, which we'll talk about. Now, what is common in this stage is something called persistent generalized lymphadenopathy. This can be common in early HIV infection or in some opportunistic infections. So basically where the virus invades those CD4 T lymphocytes. So what do we need to know about this? That it's expected, it's rather normal that we would see that around the time of diagnosis. So once we go from the acute infection, person ends up with the asymptomatic or chronic infection. At this point, if we do nothing, the person will more than likely develop AIDS within about 10 years after the HIV infection. That's called the period of latency. If the person was not tested at the time of their illness or shortly after, they may not know they have HIV. They become a latent reservoir, right? They may not be aware, and because of that, they may continue to use those to engage in high-risk behaviors. Remember, once the person has a drop in their CD4 count to under 500, they're at increased risk for infection. So that stage 2, chronic or clinical latency, the person can have HIV as the CD4 count starts to drop, but they have no AIDS defining conditions, which are category C. This is where the person becomes symptomatic. So remember, the HIV stage 2 is kind of broken into asymptomatic and symptomatic. So once they experience some symptoms, you would say that they would be symptomatic. So once the CD4 count drops, and we do use the CD4 count as a marker of disease progression, the person is more likely to experience things like fever, night sweats, diarrhea, headache, fatigue, but they don't have any AIDS-defining illnesses. All right, so here's a little bit more on the symptomatic. Once the T cells start to decline closer to 200, it's more of an active stage of HIV. We kind of talked about that, and some of the opportunistic infections that are present, I have listed here for you. Person may show up with oral pharyngeal candidiasis or thrush, but it doesn't go past the back of the throat, past the oral pharynx. Shingles, herpes, and then oral hairy leukoplakia. Then eventually, if we don't keep the person's CD4 count, this is an or statement, right? The person has CD4 count less than 200 or documentation of the AIDS defining conditions. And at that point, the person is said to have AIDS. And so this is AIDS, right? The criteria is established by the CDC. And I always encourage you guys to definitely go to the CDC website and look at it, because sometimes criteria changes, and that's how we become good practitioners, is by always staying up to date. So basically, AIDS is a severely compromised immune system. At this point, the life expectancy would be 3 years without treatment. So the CD4 current criteria is, CDC criteria currently is CD4 count less than 200, or the opportunistic infection, or an opportunistic cancer, like Burkitt's lymphoma, invasive cervical cancer, Kaposi sarcoma, or a primary brain lymphoma, or wasting. So we'll talk about wasting a little bit. But here are the AIDS-defining illnesses. Something to be aware of. All right, so HIV wasting syndrome is defined as a weight loss greater than 10%, and it often comes along with fever and chronic diarrhea. The person ends up with fatigue. You have a little bit of the patho there about the tumor necrosis factor. It's nice to know, not need to know. But the labs that we check are there, albumin, prealbumin, TIBC, so you should recognize that from anemia. And then our BMI. So BMI less than 18.5 is indicative of wasting. And then I have an example of that. And some strategies. You can pause and just take a look at this. I want to draw your attention to some of the medications. Megace, a very common medication to use. And let me just add this to my dictionary. And Marinol, might recognize that from one of the THC stuff, so cannabinol and Marinol. And then there's some engineered meds, so human growth hormone. And I wanted to take a moment and talk about Kaposi sarcoma. So Kaposi sarcoma is one of those cancers that is synonymous with AIDS infection, right? It's one of those cancers that a person generally doesn't get at all unless they have HIV AIDS. It's the most common HIV related malignancy. Some of the others would include lymphoma, non-Hodgkin's lymphoma, CNS lymphoma, or invasive cervical cancer, like we talked about. So just recall that the lesions that we see on the skin, those lesions are actually all over the inside too. They're all over the organs. And this is the Kaposi sarcoma in that movie Philadelphia. That's what Tom Hanks had suffered with, and the lesions that he had. And for this, radiation is used as a palliative treatment. All right, so let's go back to our patient. It says he tells you that he drinks at weekend parties and has smoked pot, but not recently. He reports no regular use of injection drugs, tobacco, or anabolic steroids, but that sometimes he gets so drunk he doesn't remember. So how would you rate his risk and why? Right, so he's at high risk for contracting another STI and or HIV because of his active sexual life with multiple partners, direct contact sex with same-sex partners, and his inability to recall possible exposure when under the influence. So he would be high risk. All right, so some of the diagnostic studies that we use for HIV for screening. The most common and useful are the ones that screen for antibodies and or antigens. But here's the issue. The window period may preclude accurate diagnosis because that usually can take up to about 3 weeks. So if you have a negative test but a high-risk behavior, the recommendation is to repeat that test in 4 to 6 weeks, right? Some of the other tests that we have home tests and we have rapid tests, and those are definitely available, but they have to be confirmed by the assay test. And then we also have the viral P24 antigen testing. That's also possible for early disease, but its use is very rare. It's used very rarely, and it doesn't become useful after seroconversion. Here's the CDC's recommendations for HIV testing. There's the algorithm right from there. So basically, if they're positive, then you want to do the HIV-1, HIV-2 clades, see what you're dealing with. And then if it's negative, then routine testing is recommended. Again, unless you might be in that window period. So it's probably a good idea to get screened if you think there's an exposure. All right, so with HIV, our monitoring for HIV is the CD4 count and the viral load. So remember, our normal CD4 count is 800 to 1200, and the lower, and for us, the viral load is something that we always want to monitor because the lower viral load means less active disease. So if we have high viral load, our CD4 count is going to drop faster, and if it's lower, then we actually have a longer time that the person can live with this chronic disease. So viral load's a better predictor of HIV progression than the CD4, and it actually is what we use to track the response to ART therapy. Some of the other labs are important to know. We may have some abnormal labs just based on the illness itself. And that could be caused by the HIV, it can be caused by opportunistic infections and diseases or complications of treatment of HIV. So we might end up with decreased white blood cell counts, especially our lymphocytes and neutrophils, thrombocytopenia, anemia related to antiretroviral therapy, and also it's just anemia of chronic disease. And then liver impairment from the infection itself. But the other thing is that the person may also have co-infection with hepatitis B or C, which can limit the treatment choices. So we need to test for those early. Phenotyping and genotyping of HIV to test for resistance and help guide the treatment of choice is very important. HIV-1 mutates quicker than HIV-2, so we want to know what we're dealing with. So at the time of the diagnosis, this is what we really do want to have. We want to have the HIV antibodies, the CD4 count, viral load, check the CBC, the CMP, check for hepatitis B, hepatitis C, check to see the genotype. We want to get a tuberculosis test. And then our treatment, right? It's a big deal to put these people on treatment. The interprofessional care of the patient with HIV is very important. Not every patient goes on ART right away, and we can discuss that later, though the goal would be to get everybody on ART that is eligible for it. That's the interprofessional care. So our first patient visit, you're going to want to definitely get your baseline data, get the rapport established, the health history, and then patient teaching, very important. So we're going to come back to our patient. So it says AO returns to the clinic 3 months later after refusing HIV testing or teaching. And he's now concerned because one of his partners was just diagnosed with HIV. He wants help. What should you tell him about HIV testing? You can go ahead and pause and think about that. When you're ready, press play again. So HIV involves testing a sample of blood or oral fluid for HIV-specific antibodies. It's important to work together, and testing is the only way to determine if he has HIV. So early treatment and support is very important for his health, and you'll provide him with information and support to help him understand and deal with his concern. For the provider, you need to know more about his available support system, when the last risk of exposure occurred, and to remember that testing may need to be repeated at intervals for up to 3 months after each possible exposure. Let him know that rapid testing is available at your clinic and that results are available in 20 minutes, but it is more expensive than standard testing and should be verified with standard testing. And it's important to protect himself and his partners from further risky behaviors during the 3-month interval until final results are known. So some drug therapy, right? So the main goals of our drug therapy are to decrease the viral load, keep the CD4 count up so that we can avoid opportunistic infections and those HIV-related symptoms, and delay progression to AIDS and prevent transmission to other folks. The goal is to actually decrease the viral load to undetectable. And then the other thing to look at is there are a ton of interactions, especially with the over-the-counter drugs. So we need to do a thorough medication history for our patient who is on antiretroviral therapy or if they're considering going on it. And then also look at their herbal therapies as well. Opportunistic diseases do complicate management of HIV infection, and they are more common as the CD4 count drops. Remember that our CD4 count remaining elevated to normal limits is what helps us prevent these infections. So we'll talk about a little bit of these, some of these opportunistic infections here. So pneumocystis jirovecii, which used to be called PCP. This is one of those that if a person shows up and they have pneumocystis pneumonia, then if we don't have an HIV test on file for this patient, we need to definitely do one, right? It's one of the most common. Person is got a pneumonia. They can have severe hypoxemia, tachypnea, so everything we looked under respiratory, pneumocystis pneumonia, right? People with a functioning immune system do not get PCP. Here's the treatment. So steroids, antibiotics, and if their CD4 count drops under 200, you'll see a person be put on Bactrim. Again, PCP easily treated if you have the antibiotic. However, without a functioning immune system, this is just bad news. Toxoplasmosis. Let me move that over here. I wonder why that did that. So toxoplasmosis is the most common central nervous system opportunistic infection if they're not on ART. And you can pause and look at that for treatment and otherwise. And let me bring this over here. Sorry, I have a screen capture on here, so I don't know what happens. Cryptococcal meningitis. Again, you can pause and read through some of these. But meningitis, that's going to be central nervous system, and we do diagnose it with the cerebrospinal fluid culture and sensitivity. And the treatment is there, amphotericin B for 2 weeks, and then fluconazole for 8 weeks. And there's the side effects of amphotericin B, right? Serious side effects: anemia, kidney liver failure, some dyscrasias with the electrolytes. PML, it's a central nervous system demyelinating disorder. We're looking for confusion, blindness, aphasia, paresis, and you could see this on the patient's baseline MRI, and then 6 months later he has the lesions there. Severe neurological disabilities can occur as a result of this. Cytomegalovirus, CMV, causes retinitis, colitis. Retinitis is the most common opportunistic ocular infection and the leading cause of visual loss in AIDS patients. Represents about 90% of all infectious retinitis in that patient population. It results from reactivation of a latent CMV infection. So the people who are at risk is if that CD4 lymphocyte falls below 50, they have HIV-1 RNA level greater than 100,000, who have been previously diagnosed with opportunistic infections are at particular risk. The patient may be asymptomatic, or they may have floaters, photopsias, or scotomas, right? So what are we looking for? Decreased visual acuity, floaters, fundus exudates. And then there is some treatment. Localized ocular treatment may include intravitreal ganciclovir, foscarnet, or citivir. So look at the ganciclovir. It's an antiviral. That's a picture of the retina. All right, so to prevent transmission of HIV, we do have now PrEP, pre-exposure prophylaxis. It's a Truvada. The commercials are out there in full force now. You can see all of the different treatment opportunities. So basically, the person takes part of the regimen on a daily basis, and then can be used with some other interventions to prevent the transmission of HIV. Little thing about nursing management is do not make assumptions at who may be at risk. You would be surprised, right? So the folks that we definitely know who are at risk are anybody that received a blood transfusion or factors before 1985, if they share any drug-using equipment, so needles or anything similar. Anybody who's having sex and has had an STI. Let's go back to our patient. So AO says he will not be abstinent, but is willing to use a condom during contact sex. So what are the main points you need to cover when teaching him about barrier methods? Again, you can pause and think about it, and then press play when you're ready. So we only want to use condoms that are made of latex or polyurethane. Store the condoms in a cool, dry place, protect them from trauma, and do not use them past the expiration date. Use only water-soluble lubricants with condoms. Place the condom on the erect penis before any contact is made with the partner's mouth, vagina, or rectum. And hold the condom at the base of the penis and remove the penis and condom from the partner's body immediately after ejaculation. And then dispose of the condom by removing it, wrapping it, and discarding it, and never reuse the condom. So what are some things that we can talk about HIV, right? Health promotion. HIV infection is preventable. Prevention is the critical component. And if we can't, if the person is not able to prevent it, we can do other things. We can help, right? Modifying, we can at least decrease the prevention or decrease the spread. And again, pause and read this. It's common sense for nurses. Abstinence is the only way to be 100% sure that you will not get HIV from sexual intercourse. All right, so talked about perinatal transmission a little bit. And remember, our folks who are on a lot of these ARTs, some of them are teratogenic. They're not to be used during pregnancy. And there are several that are absolutely safe and recommended for pregnancy. And then for us as healthcare workers, we need to decrease the risk with work, right? So how do we do this? Let's take a look at the most common way that we're going to get exposed is through needle sticks. If we're splashed with other materials, they just don't have as high viral load, right? Somebody's saliva doesn't have as high viral load as the blood. So needle sticks. Here's what we need to do. Train and do not bypass the safety mechanisms. And a lot of this happens with being distracted, being overworked, like or understaffed, and that can increase the risk. And if you were to actually get a needle stick, wash the puncture site. Don't squeeze it to express the blood. Believe it or not, they found that by doing that, you actually hasten the cleavage of the virus because it's causing inflammation to that area. And there's no evidence that squeezing it reduces the transmission. In fact, it may have the opposite effect. If you are exposed, this is basically the thought process behind if you need a post-exposure prophylaxis. I've been stuck with needles. It's not a matter of if, it's a matter of when. The most important thing for me was to have the patient tested so that I knew what my risk factors were and made that decision. Okay, so we already mentioned HIV testing is the only sure method of determining HIV infection. CDC does recommend universal voluntary testing as part of routine medical care. You can see it in practice today. I went to the ER for something not that long ago. Every patient that comes to the ER, they're offered an HIV test. I'm offered every single time I see my provider. And as we said earlier, 14% of people living with HIV are not aware. All right, as you talk to AO about the barrier method of protection, he begins to look away and seems to lose interest. He finally says, I don't know if I can do this. So what are some cultural considerations that may be a risk factor here? So if you recall, AO is Hispanic, and Hispanic culture may influence an individual's acceptance of condoms. Condoms not only protect an individual from disease, they prevent conception. So contraception is problematic for many Hispanic cultures, either because of religious prohibitions or the desire to have children. And Hispanic men may have also been raised with the cultural concept of machismo, which supports the notion that men are in control. So this may interfere with the condom use in heterosexual encounters if the condom use is seen as weak and not using condoms is seen as a way to control the female partner. All right, so at the time of diagnosis, the patient may show up with anxiety, fear, panic, depression, and guilt, basically similar to any other life-threatening chronic disease diagnosis. Their potential to become isolated socially. And for this, when they're diagnosed, this is very important nursing care that occurs here. At the time of testing, we want to provide the telephone number to receive the results, make an appointment at the time of testing to receive the results. So if you're testing somebody, make the follow-up appointment at that time. And then we need to ensure they understand their diagnosis, provide any referrals that are needed, clarify misconceptions about transmissions, their partners, needle sharing, let them know they have to refrain from donating blood plasma or organs. And the first few months are very important for accessing medical and support services. We have to help the person as they navigate the treatment, establish adherence, and maintain the behavior changes. And we should follow up in 3 to 6 months to assess their compliance. We talk about compliance. What does some of that look like, right? People living with HIV, that's PLWH, why do they not get virally suppressed sometimes? This is part of it, right? That it's expensive. There's stigma. They may not have correct information. So this is where nursing becomes very important. We're going to keep plugging along. Again, if you get tired, you can press pause and come back to this at any time. All right, so we're going to start talking about antiretroviral therapy. There are clinical guidelines available for treatment decisions. Things to know, though, ART is very complex. There are severe side effects. Doesn't always work. It's very expensive. But the one thing that I do know is that people who are diagnosed with HIV, I believe, are eligible for Medicare. Same thing, premature babies, if they're born before a certain week and a certain birth weight, they're eligible for Medicare, as well as people on dialysis to help control their costs. So again, clinical guidelines are available. The most important decision to be made here is the patient readiness for treatment. Because in order for the medications to work, the patient has to be compliant and adhere to the treatment. Otherwise, we have the potential to get mutations in the virus, which would make it so that any treatment would not work for it, right? So remember, noncompliance, combinations in one pill helps improve adherence. Person may have depression, cognitive impairment, poor social support, low literacy. They may be homeless, poverty, some potential substance abuse issues as well, then the side effects. So again, patient readiness is the most important concern. Promoting a healthy lifestyle is imperative to delay progression, whether or not the patient goes on ART. And what does this look like? This looks like nutritional support, avoiding alcohol, smoking, and drugs, getting their vaccines, rest and exercising, reducing stress, avoiding infection, and getting regular medical care. So whether or not a patient goes on ART, we still need to promote that healthy lifestyle. And then nursing care of the HIV patient includes care for them and any side effect of treatment. So some of the most common side effects are nausea, vomiting, diarrhea, fatigue, metabolic disorders, and some of these metabolic disorders are things like lipodystrophy, hyperlipidemia, insulin resistance, hyperglycemia, avascular necrosis, osteoporosis, lactic acidosis, renal disease, cardiovascular disease. If a person develops the metabolic disorders, often will change to another ART. So the nursing care for that focuses on early identification. All right, so let's talk about IRIS, immune reconstitution inflammatory syndrome. Wasn't something that was talked about in the book very much, but I wanted to put it in here because I think it's an important concept. So if a person has a delay in starting ART, or at the time of diagnosis they already have a terrible immune system, they may have opportunistic infections, but because their body is not fighting, they don't seem sick. Right? This is the whole thought process behind, if you look back to our cancer conversations that we've had about people with decreased immune systems, that even a slight fever at that time becomes a medical emergency. It's the same thing kind of here, except so the person may have an infection, but then when we start to put them on the antiretroviral therapy, then their immune system comes back online and then basically has a mega reaction to the infection in the body. So people who are at risk for IRIS would be those with advanced HIV who introduce heart, so they've not had medication before. Somebody has a low CD4 and a high viral load. Anybody who has HIV, TB, or another opportunistic infection. And how do we fix this? If we have the immune system comes on too much, usually anti-inflammatory medication, steroids. So now we're going to start talking about some of the medications that we have. And remember the different enzymes that HIV used. And so our treatment does follow along with those. And the medications, they work at various times in the replication cycle. We use multiple drugs to prevent resistance, usually 3 or more. Again, many interactions with over-the-counters, and compliance is the number one single most important factor when deciding on treatment. So the NRTIs, the NNRTIs, the book does a good job. Basically, the NNRTIs, they block development of the HIV DNA chain. They may block process that converts RNA to DNA. And then some of the medications here are listed for you, and the side effects as well. Protease inhibitors, these ones basically end with the NAVIR ending. So you might recognize them as darunavir, ritonavir. Basically, they prevent the completion of the viable virions. And then the fusion inhibitors are listed there. They end in tide, fusion inhibitors. And the little thing about ritonavir, which is a protease inhibitor, it's not really used for its antiviral action, but it inhibits the enzyme that metabolizes the main protease inhibitor. So it allows the medication to stay in the system longer. So the integrase inhibitors are here. They bind with the integrase to prevent HIV from inserting itself in the DNA cell. And some of the others that aren't really, they're a CCR5 antagonist. That's one of the meds we may use for people who have been on treatment as well. Again, not so much in the book. I think I'll give you guys the handout of the HIV medications directly from the book to kind of get there, but that's them. And then there's something called highly active antiretroviral therapy. So again, this just, I don't need you to memorize this, just to understand that if a person starts on regular antiretroviral therapy and then they continue to have viral loads, then we increase the number of medications that they're on. So that's what this is after. And again, compliance becomes some of the most important things. We've talked about reasons for noncompliance. I actually hate to use that word noncompliance, but I guess it's appropriate here. The inability to be compliant. And if a person stops their ART, that may have implications for restarting treatment in the future. So we want them to take all their medications on time. I know I've already mentioned this, but mentioning it again, and here's a slide for you. And I actually put a picture of lipodystrophy. You can see it's basically the fat is redistributed across the body and taken from the face. And then again, if we have the metabolic symptoms, usually the providers will look at changing it to a different regimen. We talked about delaying disease progression. This is whether or not a person is on antiretroviral therapy or not. Okay? And then let's go back to our case study. We're on part number 8. It says AO tells you he really cares about one of his partners. So what do you tell him about informing his previous sexual partners about his gonorrhea? And what should he tell them about the HIV infection if he tests positive? So he should be encouraged to inform his sexual partners about his gonorrhea. He should be told that gonorrhea is often asymptomatic in women, and his recent female sexual partners need to be tested and receive treatment, or they may develop infertility. His male partners also need to be diagnosed, treated, and counseled about transmitting this infection to others. It's a reportable disease, which means that the diagnosing clinician must report AO's case to the health department. And personnel at the health department have been trained to trace the sexual contacts of people with sexually transmitted infections and to tell them about their risk for infection. So he'll be encouraged to provide the names of his recent sexual partners to the health department. And then the health department personnel can make non-disclosures anonymously, so not using his name. HIV is also a reportable disease, and partner tracing and notification can be handled in a similar manner. If AO chooses to notify his partners himself, he should be provided with assistance and counseling on how to approach the discussion and how to prepare for his partner's reaction. And again, common disease and drug side effects, anxiety, fear, and depression. They will need support with the diagnosis, education about their high-risk activities, needle exchange programs, appropriate referrals, safe sex practices, risk reduction. And nursing care of the HIV patient includes care for them and any side effects. So nausea, vomiting, diarrhea, fatigue, some of the metabolic disorders, which we talked about. So it says 1 year later, AO returns to the clinic, stating he's had night sweats and a productive cough for 1 week. His CD4 lymphocyte count is 76. He's lost 13 pounds in the last month. His record shows a history of positive PPD. So what do you think is happening? So what wasn't implicitly said in here is that he must have been infected with HIV, and hopefully he was tested. But if he wasn't, if he comes back to your clinic, this opportunistic infection, he likely has HIV. We think that his signs and symptoms are very suspicious for Mycobacterium tuberculosis. And collectively, the night sweats, productive cough, weight loss, and history of positive TB tests indicate that this is the diagnosis. All right, we're going to take a moment to talk about end-of-life care and this particular photo. This was in 1990. Life magazine published a photograph of a young man named David Kirby. His body wasted by AIDS, his gaze locked on something beyond this world, surrounded by his anguished family as he took his last breaths. This image, taken by a journalism student named Teresa Frary, quickly became the one photograph that most powerfully identified the HIV/AIDS epidemic that by then had seen millions of people infected, many of them unknowingly around the globe. This patient, he was born and raised in a small town in Ohio. He was an activist in the 80s on gay rights, and while he was living in California and estranged from his family, he contracted HIV. He got in touch with his parents and asked if he could come home. He wanted, he said, to die with his family around him. And the Kirbys welcomed their son back. So understand that end of life is a complex emotional time. And although HIV is akin to a chronic diagnosis, it can become quickly terminal, especially if we have increased strains that are not treated appropriately, or through noncompliance of the patient are allowed to mutate. All right. A couple of things about gerontological considerations. HIV patients are living longer, and the folks that are older, they develop the diseases of aging and HIV, but they often develop those earlier. They're more likely to experience polypharmacy and increased stigma. Remember what I said, don't prejudge who is having sex and who has risk factors for contracting AIDS, HIV. All right, we'll do some questions here. It says, diagnosis of AIDS can be made for a patient with HIV with what? You guys can pause it, but I'll just go on to the answer. Pneumocystis jirovecii. So CDC has established criteria for the patient to be diagnosed with AIDS. AIDS is diagnosed when an HIV positive individual develops at least one of several criteria. So this could be the CD4 count less than 200, or opportunistic infections such as PCP. Candidiasis infection must be of the bronchi, the trachea, and the lungs or the esophagus, not only in the mouth. So that's your rationale there. Okay, question number 2. Nurse is teaching a newly diagnosed 34-year-old male about his HIV infection, so which statement by the patient would indicate the patient needs additional education? So you can pause and choose your answer, but I'll go on. The correct answer is D. Persons with undetectable virus are still infected with HIV and may need to take their HIV medications on a daily basis to keep the virus suppressed. Third question for you. Nurse is caring for a patient who's receiving antiretroviral therapy for treatment of HIV infection. Which assessment best indicates that the patient's condition is improving? So which one of those tells us that they're doing better? The answer is the viral load, right? The goal of antiretroviral therapy in the treatment of HIV are to decrease the viral load and then maintain or increase the CD4 count. So combination drugs are prescribed to prevent or decrease drug resistance. Some of these drugs may impair liver function, and increased aminotransferase levels indicate impaired liver function. So that would be undesired. All right, nurse informs the patient with bacterial pneumonia that the most important factor for antibiotic treatment is what? And here, of course, it is that all of the supplied antibiotics should be taken. To prevent the emergence of antibiotic-resistant organisms, patients need to take the entire prescription even if symptoms have resolved. Antibiotics should not be used routinely to prevent bacterial pneumonia. All right, guys, that completes HIV. Thank you.